Thank you so much. And I'm just so honored to be here with Dr. Bigfoot and Dr. Houses, two very good friends and colleagues that I admire a great deal. And I also appreciate the opportunity to look at some of the epidemiology and challenges related to suicide in our populations, but also thinking about this in terms of prevention and how can we link the best of modern science and cultural approaches to do something meaningful about the challenge. So go and go to the next slide. And much like Dr. Houses, I like maps as well. And this map, I think, is really important to understand in terms of loss of territory, loss of resources, and intergenerational trauma, as well as intergenerational poverty. So, of course, the entire continent at one point was indigenous land, and that's changed dramatically over the years, obviously because of colonization and challenges related to access to food sovereignty and traditional ways of life. So when we think of suicide prevention, in many ways, it's wellness promotion that we're talking about. And I've done a lot of my work in recent years looking at the impact of intergenerational trauma, but also adverse childhood experiences on health outcomes. Go and go to the next slide. This image is, I know it's a very busy slide, I apologize for that, but it's looking at the timeline essentially between historical trauma and genocide all the way through our chronic disease disparities, as well as our disparities related to mental health and suicide and other challenges. So we've had, of course, boarding school experiences, forced participation in boarding schools in many cases. My mother is a boarding school survivor, so this is not ancient history. This is something that's within reach in terms of people who experience this very directly. And then we also have stressors during pregnancy, childhood stressors, and adulthood stressors. And I think one area where we can do much more intervention is looking at adverse childhood experiences. And we know that the impact of ACEs is really pervasive. It's not just in the mental health arena, but also physical health, and also has an impact on life potential. So go and go to the next slide. And this is actually the ACE pyramid from the CDC National Center on Injury Prevention. And usually the ACE pyramid has adverse childhood experiences at the base. But I really appreciate what they've done here and recognizing that there are social conditions and a local context that can put some families at greater risk for exposure to adverse childhood experiences. And then, of course, generational embodiment and historical trauma can lead to the social conditions in a community that put us at greater risk for adversity during childhood. And then what we see with ACEs is disrupted neurodevelopment and subsequent social, emotional, and cognitive impairment. And quite often, these children are dubbed the problem children, but through no fault of their own, just growing up with some significant adversity. And then what we see, unfortunately, is adoption of health risk behavior, early onset of disease, disability, and social problems, and early death. And one of the things that is within the data that is very concerning is suicide among our young people. In other populations, we tend to see increasing suicide rates with advancing age. For American Indians and Alaska Natives, we see a peak of suicidality in the teen years and early adulthood. So we are really dealing with a crisis in terms of the need to prevent suicide, particularly among young children. But it seems to me that the area to potentially intervene would be preventing adverse childhood experiences. So go to the next slide. I was a co-principal investigator in what was called the South Dakota Health Survey. And with this survey instrument, we basically cut and pasted from other validated surveys, including BRFIS and others. So we had basic information regarding age, sex, and race, self-reported health status. We also did mental health screening. So not self-reported, but we used PHQ-2 for depression, GAD-2 for generalized anxiety disorder, AUDIT-C for alcohol use disorder, et cetera. And then we also included the ACE questionnaire, adverse childhood experiences. So go to the next slide. And in the South Dakota Health Survey, we were able to have a very good sample. We had well over 8,000 survey respondents. 7 of the 9 tribes participated. We had well over 500 American Indian respondents. But if you look here, I know it's a little bit of a busy slide, but on the far right is the reservation-based American Indian population in light blue within each grouping. And unfortunately, statistically significantly higher risk for depression, anxiety, and PTSD among American Indians. And clearly, these issues lead to self-medication with substances, but also increased risk for suicidality. Go to the next slide. The other thing that was very concerning within our data set was the terrible disparities in adverse childhood experiences. So the ACE score is essentially 0 through 10, and we look at various measures of abuse, neglect, and household dysfunction. And as you can see, for each area or each domain, for American Indians, it was statistically significantly worse for American Indians in South Dakota. And we had some people with ACE scores of 10. So what that means is that we had people who had experienced each of these adversities during childhood, and obviously makes a significant impact on outcomes. Go to the next slide. So we saw that, of course, each individual score is significantly worse. Not surprisingly, the overall score was much worse as well for American Indians. So what I call your attention to is that for American Indians, only 17% of the American Indian population in our data set had 0 ACEs, whereas 50% of the non-Indian population had 0 ACEs. I mean, ideally, it would be much higher than that, right? We don't want to see these adverse conditions during childhood. But look at the number of greater than 6 adverse childhood experiences. Almost 20% of the American Indian population had 6 or greater ACEs, whereas only 4% of the non-American Indian population. So many of our people are dealing with very significant adversity and puts us at much greater risk for suicidality. Go to the next slide. So what do we do about this? And when we think about trauma, whether it's historical trauma or adverse childhood experiences, we have to recognize that this does have an impact in a holistic way. And when we look at the medicine wheel as a model and looking at 4 directions of who we are as people, and we have spiritual, mental, physical, and emotional components of who we are. And trauma affects all domains. Of course, we have physical trauma, and we need level 1 trauma centers to address injuries. But much of the work historically has been done in psychological and emotional trauma. But what I would put forth is that for Indigenous populations, based on colonization, loss of territory, our deep-rooted cultural and spiritual connectedness to land, place, and to earth, we have a lot of land-based healing modalities that are no longer available because we've lost our traditional territories. We've also had spiritual trauma, and I don't think we've done enough work in this area to really understand the impact of that, and then the risk for all kinds of challenges, including suicidality. We can go to the next slide. So when I think about spiritual, emotional, physical, and mental interventions, just think about in the emotional realm, social connections are so important. And one of the challenges during the pandemic is that we were promoting social distancing. I wish we had never used that term. It should be physical distancing. 6 feet apart is not social, that's physical. And unfortunately, with more social isolation, we've seen increasing rates of suicidality and certainly overdose deaths due to drug misuse and abuse. So when we think about this from an emotional perspective, we need to be promoting social connectedness and having counseling that could be using the best of modern methods, but also our traditional healers have training in culturally based counseling methodologies that need to be incorporated to ensure that we have an equitable approach. We know that even physical activity has a big impact on health, not just physical health, but mental and emotional health. And even the types of foods that we eat have an impact on the microbiome and subsequently behavioral health as well. Historically, in the mental arena, we had our own types of meditation and our own types of mindfulness. And when we think about things like cognitive behavioral therapy and being mindful of what we're thinking about, we know that we can have an impact on physiology if we're focusing on things that we're grateful for, as opposed to focusing on things that might cause us to be upset. So we had ways of doing this traditionally. So in many ways, CBT is traditional medicine, and we need to frame it in that way and have culturally appropriate and community-based initiatives that are using our traditional ways of healing. And then finally, looking at prayer and reconnection. I've seen so much healing in my communities when people are reconnected to language, reconnected to culture, reconnected to ceremony. And I think these things are underestimated in terms of their value in the current scientific approach. We need our own science to more adequately address these challenges. So I'm going to go to the next slide. So when we think about the medicine wheel and recovering from trauma and promoting wellness in our populations, a big part of that is ceremony and cultural connectedness. And that needs to be a part of our equation moving forward. We know the epidemiology, we know the data are terrible. We also know that our current interventions have not yet yielded the types of results that we want. So we need to be more open-minded as medical systems and research institutions to recognize that one size does not fit all, and we need to have more appropriate culturally based interventions to address these challenges. So when I think of the word recovery, the root of that is cover, right? And we've always used blankets for healing, and go to the next slide. And that sense of covering and that sense of ceremony and acknowledging the healing power of warmth and feeling wanted and feeling cared for. We don't take advantage of that enough, I think, in our healthcare systems, but we certainly are doing that more in academics. If you go to the next slide, you can see that part of what we do for our graduates that are moving into health sciences is we have a blanket ceremony. We have on the left, that's South Dakota State University nursing. On the right, that's North Dakota State University public health students. Go to the next slide. And then just from a couple weekends ago, we had our University of North Dakota powwow where we graduated our Indians into Medicine and other health sciences students. It was just wonderful to see that healing power of cultural connectedness and acknowledging the strengths and resilience of our people. And that has to be a part of the equation as well. Go to the next slide. And this is my last image. And culturally, we also learn a lot from the natural world. And when we observe the bison herds, what we see is that during a storm, during a blizzard, it's the strongest bisons that face the storm directly and protect the ones that are behind them. And I would put forth that any of us who have the opportunity to work in this space, not only is it a privilege for us to do this, it's a responsibility. And we have limited time to do our work on this earth, but it's vitally important time. And we have to recognize that for those of us who are privileged enough to have strength and to develop programs, we have to do this in a culturally meaningful way. And we have to be those strong bison standing in front and facing the adversity so we can protect those behind us that might not be able to protect themselves. And go to the next slide. That's just my email address and contact information. And I'm hoping we have really good dialogue about incorporating the best of modern science, but also the best of cultural approaches to promote wellness and prevent suicide. Thank you very much.